So if we do get a patient who has the symptoms and signs that we discussed, that is commonly a presentation of initial disease, it is not very specific. So if the patient has prolonged history of abdominal discomfort, dyspepsia, epigastric pain, gastritis, decreased appetite, or if there is presence of any blood in the vomitus or stool, melena. So we need to investigate the patient to rule out serious issues like gastric cancer. So the basic investigation that we do is that we do a full blood count, that is complete blood count, to check for whether there is anemia, whether the bleeding is because of low platelets, whether there is underlying infection which can lead to rise in TLC. And then liver function and kidney function tests are also checked to look for any the baseline organ functions which will help us in treatment planning. Generally, amylase, lipase, they are not generally routinely done as a part of workup for gastric cancer, but to rule out involvement of pancreatitis as a differential diagnosis, and amylase and lipase should also be done. And certain blood tests which are called as tumor markers, which are raised in certain cancers. So as such, there is no specific tumor markers for gastric cancer, but we do see that CEA and CA19-9 can be elevated. They are not specific, but they can be used for monitoring, and they also increase the sensitivity. Then if there is presence of melena, then stool should be examined for occult blood. Then subsequently imaging can be done. So what are the specific tests that we do is that the diagnostic test, the specific test is the presence of, is to do an upper GI gastroscopy or endoscopy followed by biopsy. So nowadays we hardly do barium studies for gastric cancer. Upper GI endoscopy is the most specific and diagnostic test for gastric cancer. So once clinically and based on these scopies, we are able to identify. Next slide. So once on the basis of the scopies and clinical picture, we are able to identify that this is probably a gastric cancer. Then we should do further imaging. So further imaging, whenever feasible for a gastric cancer, if it is available, and then a PET CT scan should be done. So PET CT scan is highly sensitive and specific. Although very small lesions, especially in the peritoneum, small lesions of 0.5 centimeter, it can be missed by PET CT also. So some centers do a staging laparoscopy. So staging laparoscopy is done for those patients where we have in the PET scan, we see that the disease is limited to the stomach, but we are not sure that it has definitely not spread. So staging laparoscopy means that as a part of before surgery, as a routine practice, staging laparoscopy is done to rule out presence of peritoneal deposits. So sometimes there are studies that staging laparoscopy can upstage the tumor in around 15 to 20% of the cases. So if we do found something like peritoneal deposits or positive fluid, then the treatment is changed. Then the entire treatment is changed. Then there is no definite role of surgery in this case, because the patient has become a stage 4 disease. In certain scenarios, CT, MRI, or ultrasound can be done for case-to-case basis, but generally PET scan is the imaging modality of choice. Next slide. So as I discussed that whenever you suspect a patient who's having symptoms and signs of gastric cancer, then upper GI endoscopy is the gold standard for confirming and diagnosing it. So upper GI endoscopy will not only diagnose it, it will also help us to take biopsies. And these biopsies we can look into and check whether it is adenocarcinoma or GIST or lymphoma or it is some other tumor. And it is also very safe investigation of choice. So this is one of the picture that in a polypoidal growth. So in upper GI endoscopy, this is how a polypoidal gastric cancer can be seen. So small bit of tissue can be taken, and this tissue can be examined. So once we have done with the signs, symptoms, and we have staged the disease, that is, we have done the baseline workup, we have confirmed it is gastric cancer, and we have done the staging. So we need to discuss ideally all the cancer patients in a multi-tumor board. So multi-tumor board, what is multi-tumor board? Multi-tumor board comprises doctors from various disciplines involved in cancer care. So that involves surgical oncologist, medical oncologist, radiation oncologist, and whenever possible, pathologist, radiologist, a palliative care doctor. So all this, we go through the case history and decide what should be the best treatment plan for the patient.